Hello, everyone. Today, I will be talking about plan approval and plan second check. For the disclosure, I have no actual or potential conflict of interest in relation to this presentation. I have not received any financial support from any company. I'm presenting our clinical experience, which may or may not cohere with the mentioned companies in this talk. Modern radiation in college departments depend on R&D systems that carry on all the aspects of the treatment process. The treatment process is very sophisticated and endorses synchronized harmony between the multidisciplinary teams to provide the best care for patients. The teams are composed of physicians, physicists, dosimetrists, therapists, nurses, and administrators. In radiotherapy, we are really very unique. We are using a very high energy, around 25 MV. Radiation therapy is a cancer treatment that uses high doses of radiation to kill cancer cells or slow their growth by damaging their DNA. As a result, shrinking or even eradicating tumors. According to the American Society of Radiation Oncology, ASTRO, more than 60% of cancer patients will receive radiation therapy, either alone or in combination with other treatment approaches, such as surgery and chemotherapy. This is the general workflow that starts from fixation and imaging, then go for the dose planning, and then the treatment, and so on. And I believe other respected colleagues talked about this already. I will take you in a journey via our department workflow, in which we are proudly to be the first paperless radiation college department in the Kingdom of Saudi Arabia. The patient is transferred to the radiation college department for treatment as per the decision of the tumor board. The booker will assign the startup care path, in which he do the patient registration. That includes demographic data such as name, age, gender, mobile, and so on. And then he assigned the radon clinic, which is the consultation clinic. The diamond shape here indicates that the physician will decide to treat or not, or maybe an imaging is requested before booking the patient for the CT simulation appointment. And we have also very nice tools in our department, which is the encounters, which is a very helpful tool to assist patient, including allergies, medical history, diagnosis, staging, and so on. We have 3 or 4 major things that should be filled in this encounter before we accept this task to be completed by the physician. And they are including the diagnosis, the consent, CT booking form, plus completing the task before it goes to the CT booking for the patient simulation. This diagram showing the care path, which represents the treatment workflow in our department, which may not be the same as others in different hospitals due to their clinical practice and regulations. It really took us some time to reach this level. Each block here represents either a task or an appointment, which is start from, let's say, the first thing, which is the CT simulation for the patient, and then goes for the dosimetric contouring, treatment planning, plan review, and then the patient will start his treatment. This care path was developed with input and feedback from all the department members. In your department, you can configure your own care path to meet the department workflow. Plan evaluation. Plan approval is mainly the task for the radiation oncologist. Evaluating a radiation plan is an essential task for radiation oncology that is becoming more complex due to the advances in radiation techniques. Multiple components are required to assess the quality and acceptability of a radiation therapy plan. which can be difficult to monitor. Therefore, there should be a documented methodology and adequate training to achieve such task. And for that, we will use a very nice acronym, and I hope you will like it. We are using the CB-CHOP acronym, which was first proposed by Dr. Raymond Mack at Brigham and Women's Hospital, Dana-Farber Cancer Institute in Boston, USA. And for each letter, we have C for the contours, B for the beam arrangement and fields, C for the coverage, H for the heterogeneity, hotspots, O for organ at risk, and P for the prescription. And I will go in details for each of these tasks. The contours. You have to review the delineated target volumes and organs at risk, OAR. It's important to ensure that all appropriate OARs are accounted for and contoured accurately. The reviewing radiation oncologist may find that a normal structure was forgotten and mistakenly not contoured, especially when some OR's contouring is delegated to others. Any expansion should be reviewed for accuracy. For example, 5mm expansion from GTV to create the CTV. This GTV may have been modified without appropriate re-expansion of the corresponding clinical target volume, CTV, and planning target volume, PTV. For the beam arrangement or fields, it should be appropriate and reasonable. Radiation therapy field arrangement and delivery technique, which ranges from simple single or opposed field to complex volumetric modulated arc therapy VMAT plans. It's important to ensure that the fields are entering the body at angles that avoid entry through excess normal tissue. In addition, beam shaping with multi-leaf collimator MLCs or other devices should be appropriate for a given target and surrounding ORs. This can be evaluated by directly visualizing each field using the beam's eye view. And it's also based on the 3D ice-dose lines overlaid on the computer tomography CT images. When treating an area in the neck or thorax, for example, one should ensure that the beams are not entering through the shoulders or arms or exiting the oral cavity unnecessarily. For intensity modulated radiation therapy, IMRT plans, one should consider the number of fields and their point of entry through the body and fluence patterns. Assessing the field arrangement and collimation may subsequently become important if target volume coverage or OAR dose limit are not optimal and may be improved with additional fields or different beam entry angles. The number of fields or arcs is also a key factor in the treatment time. A patient undergoing a palliative radiation treatment may not be able to lie on the treatment table for a long period of time, and a faster treatment may be preferable. You should also consider that the patient's immobilization and internal organ motion are considered and increased with longer treatment times. For the coverage, evaluate on graphic, plan, and DVH. The prescription ice-dose line should cover its corresponding BTV, and inadequate coverage or excessive dose spillage outside the BTV should be identified and evaluated. Evaluating the 3D graphical plan qualitatively before proceeding to the DVH, which commonly quantify the coverage. Often coverage is considered adequate when at least 95% of the BTV is treated to the prescription dose or higher, although variations are acceptable depending on the case. The DVH must be used with caution. The DVH cannot assess the appropriateness of the target and ORs. The DVH could report 100% coverage of the BTV by the prescription dose, but the BTV could be delineated incorrectly. Alternatively, 95% BTV coverage may not be met, but there may be a compromise between BTV coverage and ORs constraints, with an accepted sacrifice in the BTV coverage to avoid unacceptable toxicity to the surrounding critical organs. Furthermore, there may be excessive dose spillage through the structure not reported within the DVH. Because this information cannot be obtained from the DVH alone, we recommend evaluating the 3D graphical plan qualitatively before proceeding to the DVH. Heterogeneity of hotspots. Examining the minimum PTV dose, cold spot, and the maximum dose both within and outside of the PTV hotspot. You can refer to the IC report. The heterogeneity is conventional 3D plan is typically larger than it is for IMRT plans, taking into consideration to limit hotspots near critical organs. Refer to the published or experimental cooperative group protocols that list values for particular disease site being treated. After determining the quantitative values of the cold and hotspot, it's critical to review their location within the treatment plan. A hotspot with a GTV may be acceptable as opposed to its being in the critical organ risks. Similarly, a cold spot at the edge of the BTV is preferred to it being within the GTV or CTV. Organs at risk. Review specified constraints corresponding as those lines on plan and DVH. Review the objective assigned to the plan and identify the priority of these constraints. Certain OR have critical dose threshold beyond which severe toxicity may occur, and those constraints are not to be violated. For example, a firm constraint to the optic pathway or spinal cord may be much more important to prevent blindness or paralysis than objective for the parotid gland or oral cavity. When evaluating ORs, one should review both the DVH as well as the 3D graphic plan. The DVH provides an initial starting point to ensure the maximum dose, the mean dose, and the volume constraints are met. Prescription, total dose, dose per fraction, and image guidance. You must ensure that the total dose and dose per fraction are correctly entered. The treatment details must be also specified, including the type of radiation, energy delivery, method, 3D, IMRT, VMAT, etc., and delivery schedule, weekdays, every other day, twice weekly, and so on. The image guidance or setup verification imaging should be specified in the prescription. Image guidance requirements and techniques are at times specified by clinical protocol or are selected based on the size of the setup margins. In general, daily image guidance using COM-beam CT may be preferred when treating with the smaller PTV margins around 3 to 5 millimeters. Importance of the second check. And this is basically the main goal of the physics work or duties. Quality assurance QA radiation therapy treatment planning and delivery process is essential to ensure accurate dose delivery to the patient and minimize the possibility of accidentally exposures. To support this, computerized record and verify systems, RVSC, are now widely available in both industrial and low and middle income countries. The physics check is an essential quality assurance process, verifies that the physician intent is properly expressed in the treatment plan, the treatment plan is reasonable, and the record and verify system properly captures the plan parameters. In addition, delivery of radiation dose to the wrong site can cause significant complications with the resulting morbidity or mortality, particularly in the structures receiving the dose are radiosensitive. And you can refer to many publications for the accidents in radiation therapy due to the lack of appropriate checking methodology. Again, we will use the CB-CHOP acronym. Contours, we check the user origin, which is basically the intersection of the 3 BBs, ball bearings in the CT images. CT name structure must meet the name of the structure set. Body contouring full and no gaps, and you can see here the body is contoured well. Structure naming, and I advise you to go for the standardization nomenclature in radiation oncology, which is the ABM report task group 263. And couch structures are entered and it depends on the site. So we have thin, medium, and thick. For the beam arrangement and fields, we have to check the course 1, course 2, course 3, and so on. Treatment intent, curative or palliative, modality, photons, technique, 3D IMRT, VMAT, body contouring, no gaps. Field numbers for VMAT should be let's say less than 4, and for MRT less than 9, 3D should be less than 4, and so on. There is a lot of things we have to do. And this is really a very tedious, and it takes a lot of time. I mean, because it's done manual, unless you are doing it in an automation process. The coverage, BTV coverage as per protocol, plan quality index, homogeneity index, gradient index, and conformity index, normalization point, value, etc. If electrons, check depth of reference. If a 3D, check reference point, location, XYZ. For VMAT and MRT, it's a virtual point. For the heterogeneity and hotspots, heterogeneity correction should be on. Hot or cold spot location, as we mentioned before, near the critical structure is very severe, and we prefer the hotspot to be inside your CTV or GTV. Split of those between 50 to 60%, and this is very important, especially if you are treating head cases. Those fall off between 50 and 90%, and this is for SRT and SPRT cases. RVR, which is the remaining volumetric risk, which is basically body minus PTV plus the ORs, inner and outer HU values for your couch. For the organs at risks, there you have to go for the organs at risk constraints. Conventional fractionation, you are using the Quantac and R2G protocols. Have fractionated regimens, we advise you to have a look in the AABM TG101. For the prescription, we have to match the plan name, dose, etc. Imaging modality, KV, CBCT, etc. Treatment frequency, once daily, twice weekly, and so on. Gating, it's a 4D or DIBH. Bolus, thickness, location, breakpoints, and a lot of others. And this is part of our treatment prescription. As you can see, the prescription name and which site we are treating, what BTV, primary, what type of technique we are using, and what type of modality, imaging modality is there. And as I mentioned before, this is a manual process and really takes time. So a lot of people are going for the automation process. One of the biggest options that hospitals are currently developing is an automation process. There are some commercial softwares developed by companies which provide an automation solution. If you don't have resources, you can use scripting. And remember, value equal quality plus experience divided by the cost. Scripting are based on C# programming, which are fully supported by ARIA. And as you can see here, in one click, we can get the dose constraints for the structures that we have, and also the criteria passing or failing or meeting the goal or not. And also we have also here the physics check, which checks the parameter for physics, the whole list that we showed before. And also very important thing that we do the collision check. And this is very important, especially if you have non-covalent fluids. And instead of doing a dry run, bring the patient inside and then check that the gantry hits the patient or not, you can use this script, and this will give you either yes or no, your arcs passes through without hitting the patient. And with one click, that's it. We generate a report, and this report is very detailed, give you all the information that you are looking for. Vendor solutions for scripting and the APIs, application programming interface. For ARIA, Eclipse, Velocity, they are using C#, SABI, Web Services, MS, SQL, Visual Scripting, Mosaic or Monaco, they're using triggered scripts, patient access APIs, SQL. Race Station, they are using Python or Python. Hospital, EHR, the electronic health records. Rat formation, they are using the workflow automation tools. In summary, treatment plan evaluation and approval remains the key responsibility of the physician, while the second check falls on the physicist duties. Thus, developing a consistent approach is a vital role in radiotherapy. CB-CHOP is a memorable, simple approach that can be utilized to ensure key aspects of radiation treatment plan are properly reviewed prior to plan approval, second check, and initiation of radiation treatment. Capital investment is required to assure safe and accurate delivery of treatment plans, or utilizing the resources to lower the cost. Thank you very much.